Introduce Dr. Terry Flotte as our April speaker on our Frontiers in Cell and Gene Therapy and Regenerative Medicine seminar series. Terry is the Celia and Isaac Haddock, a professor at the UMass Chan Medical School. He's been the dean, provost, and executive deputy chancellor of the school since 2007. Before that, he was the chair of pediatrics of University of Florida and the founding director of their Genetic Institute and their Powell Gene Therapy Center at University of Florida. He is academically illustrious and has been one of the pioneer and leaders in translating AAV-based gene therapies into patients with over 250 publications. And I didn't realize, Terry, that you were the first in 1995 to actually treat a patient with an AAV gene therapy for cystic fibrosis because Terry's trained as a pediatric pulmonologist. Um, I would just want to say on a personal, he is also now the president of the American Society of Gene and Cell Therapy, the largest gene and cell therapy organization in the world. And I've had the opportunity to work with Terry and get to know him over the last 18 months. And on a personal note, I will say he's one of the kindest, most productive people that I have had the pleasure to meet and work with. He's one of these people who you simply cannot understand how he gets all the things done that he gets done. So I will continue to learn from him over the next year and a half, and I guess the rest of my career. So today we're excited to have him talk give us a talk, and the title of his talk is Threading the Needle Between Efficacy and Safety. So I'll turn it over to you, Terry.
Great. Well, thank you, Matt, for that very overly generous introduction. I'm really looking forward to our annual meeting of ASGCT, but also to turning over the reins to you as our next president. So let me tell you what I'm going to tell you, and then let's see if I can advance my slides. Give me one second here to hide my other controls here. Here we go. Okay, so I'm going to try to cover these topics. So I'm going to talk about some of the really serious safety issues we've now encountered with high dose AAV vector treatment. You know, Matt kindly mentioned that we used AAV in a human for the first time, which was in 1995. Those were homeopathic doses, a tiny fraction of the doses that we have now. And in fact, for a long time, I think the doses we were giving were constrained by manufacturing limitations. But unfortunately, we've now encountered safety issues that are dose related. So we talk about that, and we're going to talk about how we've tried to bring that back to the lab because we found a lot of these safety issues only in humans, and to be able to model them in animals, and not to advocate that dogs will ultimately be the best model, but to bring them back into the lab will be very important for us to be able to define all the elements that are leading to toxicity and eliminate them. I'm going to talk about some of our experience with CNS-directed gene therapy with AAV and a specific trial where we bypassed high-dose IV by doing direct intracerebral injection. And then I'm going to just very hit the high points of the overall problem we're having of in the field of making rare disease therapies like AAV gene therapies and like cell-based gene therapies accessible to people. Okay, so I know you've all heard because it's been all over the news and the literature about a number of severe toxicities and deaths that have occurred with AAV vectors when they are given at high doses intravenously. And many of these have occurred in patients with Duchenne muscular dystrophy, but some have occurred with the FDA approved product Zolgensma for spinal muscular atrophy. So I've just listed Some of the specifics about individual cases that have been reported. These have not all been with the same AV serotype. So the AV9 is the one most commonly used in this setting. And so that's where we have seen the most toxicity, but it's been seen also with AV8. And the preponderance of the evidence would lead us to think this is not necessarily a single serotype problem. Also, some novel capsids have also had this problem. What you'll notice is that the doses are fairly consistently into the range of either the high end of 10 to the 13th vector genomes per kilogram or up to 10 to the 14th VG per kilogram. Um, Many of the patients initially described had this phenomenon called TMA, or thrombotic microangiopathy, which had features in some cases of atypical HUS, hemolytic uremic syndrome. We described a case with capillary leak, diffuse capillary leak without evidence of TMA. And there have been other cases of cardiac failure, liver failure, liver, heart, and microvascular seem to be the most common recurring themes. Although, as I said, lung and kidney have been involved. Now, it's very useful with AAV, I think, to think about the toxicity in terms of time after the initial administration of the vector. So during the administration of the vector, often patients are doing relatively well. They often experience some nausea, a little bit of vomiting, that they do have some response. But within the first 2 weeks, it is very common for them to have a drop in their platelets. It is not that common for it to reach thrombocytopenia levels, meaning below the lower limit of normal, but even many patients that do not get true cytopenia do have a relative drop. And then these microvascular complications, TMA, disseminated intravascular coagulation, which is really there's a related phenomena, capillary leak, and the ARDS is the acute respiratory distress that happens from that. All happen in those first 2 weeks. So this is really the danger zone for the most of the fatal or near fatal toxicities. Then we start to see things that are really more on the realm of association with adaptive immunity. So innate immunity is often triggered in those first 2 weeks. It's not clear that all the microvascular issues are innate immune related. Some may be directly related to endothelial injury from vector itself. But in the 2 to 4 week range, we begin to see the anti-capsid antibodies, but the issues that really tend to be associated with detectable abnormalities are the T cell responses, and particularly T cell responses against the capsid. Neutralizing antibodies would be an issue or will be an issue for repeated dosing, but in this time frame, you're seeing elevated liver enzymes and T cell reactivity to the capsid most often. Now, there are patients who have null mutations where some of this is directed against transgene, but we'll bypass that for the moment. Then we have seen patients who have this longer term toxicity, and some of that is associated with anti-transgene response. There was a very nice aggregation of data from different Duchenne trials showing a peripheral myositis that occurred in this chronic phase. Karsten Bonneman led that coordination of different trials, and that was clearly related to patients who had deletions of certain exons and were exposed to those exons in the transgene product. So pretty straightforward once all the data was put together. And that's led to changes in the label indication of which mutations can get which micro or mini dystrophins. There have also been some cases of chronic liver toxicity that is very poorly understood out here in this chronic phase. In some of those, there are patients like in the X-linked myotubular myopathy where there's underlying liver disease. In other cases, not. So there've been a couple of cases happening in the spinal muscular atrophy babies But those are really uncommon relative to the thousands of doses that have been given. And I should say, I'm not talking about genotoxicity yet. Uh, that'd be too much for this talk. I think we've seen though now, and will be discussed at the annual meeting. What I think is the first AAV-induced neoplasm, AAV vector integration induced neoplasm. That's really clear, but I'll leave that as a teaser to come to Boston. Okay, so mechanisms already talked about this. In the TMA cases, there often seems to be complement activation. And there are both cases in which the complement activation appears to be related to the classical pathway with small amounts of antibody and typical antigen antibody complexes, in other cases not. There are cases where we've seen very elevated cytokines, not often, but occasionally. There are cases where we've had very diffuse triggering of cellular responses, causing hemophagocytic lymphohistiocytosis, which no one should ask me to pronounce again. Uh, we've seen myocarditis, and as I mentioned, hepatotoxicity. Now, not surprisingly, some of these toxicities are mediated by innate immunity. AAV on the surface binds to TLR2 receptors. AAV in endosomes will bind to, and endolysosomes will bind to other toll receptors, TLR9. We also can see other kinds of downstream responses, but typically these innate immune responses are triggering acute release of cytokines like IL-6 and also interferons. Um, what we've seen, again, that's really more related to the cytokine storm. Clinical tips about HLA-H that's often associated with very high ferritin levels, and as we mentioned, capillary leak can also happen. And one of the things that was really brought to our attention by Juliette Hordeau, who's now at Gemma Therapeutics, and Jim Wilson, was the fact that in some cases, the AAV vector given at a high dose is transducing a lot of vascular endothelial cells. So they showed this in a retrospective in monkeys in a variety of non-human primate species with a variety of AAVs at higher doses when they got over 10 to the 14th genome copy per cell. What they saw was at around day 4, they had accumulation of platelets marked here with CD41 and loss of the liver sinusoid endothelial marker L-sectin, which then which then would normally be present in the sinusoidal endothelium. And by doing single nucleus RNA-seq, they were able to show that this cluster here, which is those liver sinusoid endothelial cells, were expressing a lot of the transgene, and we really didn't think they should be. Because in many of these cases, it was not a ubiquitous promoter, but also it's been hard in the past when many of us have tried, at least in ex vivo models, to transduce endothelial cells. Well, Julia had also seen a case report that we put into New England Journal of a DMD patient who was treated at our institution, very unfortunately had the unexpected finding of acute respiratory distress with diffuse alveolar damage. It was actually a surprise on autopsy because it was thought the patient had myocarditis, and that was not found. So we got lung from the postmortem that was stored, and lo and behold, when we did single nucleus RNA-seq, you see this cluster here where all these are ECs. These are all endothelial cells in the lung. And you can see the red hotspots here, just as in this depiction from liver primates, that these are all highly expressing cells within the lung endothelium. And it's the lung endothelium the alveolar endothelium in the vasculature in the lung that leaks, which leads to the cellular infiltration, but also particularly these hyaline membranes here, which is albumin leakage into the into the alveoli. And you can see here, this just bar graph is showing the different types here, but particularly the capillary, the highest is the capillary endothelial cells, and along with arterial and venous. And one of the markers, two of the markers that are for endothelial injury, when we went back and looked at serum we had collected from this patient right around day 3, day 4, those spiked. So we saw the spike, the expression in the endothelium, and the dysfunction of the endothelium with leakage. So when I was presenting, again, I've presented this multiple times, and every time somebody comes back to me with another idea, and one idea Dongsheng Duan came to me with was, we have some Duchenne dogs that are older and larger, and one of the features of the DMD patients who were getting more toxicity is they were older and heavier. So he said, well, perhaps we should dose these DMD dogs that have aged and have more advanced disease with high doses of AAV. And so we did this. It was a collaboration. He had a very small number of these dogs, actually, only a handful to put through this protocol, but they're very, very obviously very precious. And between Guangping Gao and Dongsheng and myself, we put together this study. In this case, the vector we had was CAG promoter, ubiquitous high expressing promoter, gave it via AV9. We had one dog who took down at 3 days with this dose 10 to the 14, another dog at that dose at 7 days, and then two more dogs at 3 times, 2.5 to 3 times that dose. And again, this is the construct and the different probes that we used either for the vector DNA or for the messenger RNA. Okay, so how did these dogs do? Well, uh, looking for liver toxicity, we did see some elevation of liver enzymes, not all that remarkable, although in 2 of the 4 dogs, we saw that. Um, in this case, the AST rose right around the time of injection, may or may not have been, may have been more procedurally related, hard to tell. But these were not extremely high levels, but there were, again, 2 to 3 out of the 4 were above above the normal range. Alk Phos, not much. GLDH is a liver marker that is often used in DMD because it is not found in muscle, and really even less, maybe nothing there. The platelets did drop, as I mentioned, but if you look at these numbers, not into thrombocytopenic range. And the complement really did not, there was no depletion of total hemolytic complement. But we did see an increase in cytokines right around day 6 to day 7, and you can see which ones they were. IL-6, IL-2, the IL-15 was not consistent, but it was in the higher dose. Dogs, again, the purple and the red are the highest dose. So this was fairly clearly a dose-related cytokine response. Now, in one of the 2 highest dose dogs, we did see significant lung pathology, quite significant. We saw the alveolar injury, we saw cellular infiltration. We did not see by either gram stain culture or we could not find any infectious cause other than the AAV itself. And so while this dog did not have acute distress clinically, it did have some localized evidence of non-infectious pneumonitis. And then this is showing this again here. One of the things we had noticed in the patients was that they also had a high copy number in the lung of the vector genome. And here again, several often the vector genomes in the lung with AV9 are under 100 per diploid genome. We saw them more up into the 300 range. Liver sky high, that's pretty normal. Transcript numbers are also shown there, relatively speaking. Now, I should mention this work's done largely by Dong Sheng's lab and Matt Burke in the lab. What we were able to see is if we looked at both at the lung and at the well, actually, I think in this case we had the lung from all four animals. What we were able to see is that we did get vector expression, and the expression seemed to be co-localizing with the endothelial cell population. Not very high percentages, but over 10%. That's by immunostaining for the and by RNA in situ hybridization. The RNA sequence, the single nucleus RNA-seq showed a similar pattern. It actually took a while to figure out the annotations of dog lung cells, but we were able to cluster those. These were the endothelial cells, the alveolar type 2, alveolar type 1, and you can see again, kind of reproducing that the dogs that had the lung, the non-infectious pneumonitis, did have vector in the lung and transgene expression in the lung. Really interesting. And liver was more to the hepatocytes, which is kind of what we expected. So it's interesting that in the primates, the sinusoidal endothelial cells were a prime target, but not so in the human or the dog. So showing this in another way, you can see that in the highest dose dogs, we really had substantial percentages of those cells that this like slicing it by those cells that were positive rather than looking at all the cells. And you can see that the endothelial cells again by this depiction are the most commonly transduced in the lung, and the hepatocytes and some stellate cells in the liver. So the conclusions from the dog study are that we did, in fact, ultimately generate a non-infectious pneumonitis with features of ARDS. We had very limited numbers, as you saw, 4 animals overall. We saw cytokine release as well, but this endothelial cell transduction is something we think may be a phenomenon now coming across from primate, human, and into dogs, and something that may be worth trying to address in vector design. And the way we thought about this is that when AAV is encountering these endothelial cells, of course, we are observing the cytokine release. These cells are capable of making these cytokines, and also there are adjacent phagocytic cells that are able to do that, and they are clearly able then to recruit inflammatory cells that exacerbate capillary leak. They can also, by dying off, if the endothelial cells die off directly because of this overexpression shown in green, you could get exposure of the basement membrane and in the alternative complement pathway that releases the tissue factor, as it is called, that activates the alternative pathway, which can lead to further damage, activation of micro thrombosis. And the reason we think the lung is so susceptible is just the structure of the lung. And just to remind you, this is an EM that I use when I teach medical students about gas transport. But in the lung, This is a red blood cell inside an alveolar capillary. This is the airspace of the alveoli. And what you're seeing here is that this is the alveolar type 1 uh, cell, epithelial cell, and this is the endothelial cell. And this distance here is just a few microns by comparison to the 7 micron size RBC. You see, this is only a few hundred nanometers or less. So it's very sensitive. This is a very sensitive structure to endothelial injury, and you can see why the alveoli then get filled with fluid. Now, one of the things we're working on in the lab, and it's really not ready for prime time yet, but we're working on a strategy that would specifically detarget transgene expression from the endothelium. And this is the technique that's been used by many labs in different ways. But the idea would be to engineer a vector that had a binding site for microRNAs that are present in endothelial cells so that those particular, even though those endothelial cells might get exposed to a lot of the vector, they would not express a lot of the transgene product, which at least will let us to confirm whether or not it is the transgene product itself, or whether it is something more specific just to the presence of the constituents of the AAV virions. But we think this might be one way to advance um, advance beyond this particular toxicity. And as I said, I don't think dogs are necessarily the best model in the end. We obviously try to avoid using dogs in research when we can. Also expensive, and we're trying right now to back translate this into ferrets and mice. Okay, now we thought maybe we could talk a little bit, pull in this theme about how one might treat some of these conditions while avoiding those very high doses of AAV through the vasculature. So obviously, there's a lot of single gene disorders in the central nervous system and multifactorial diseases. It's a prime target, and this high dose IV, which is shown over here in the bottom right, is the most commonly used method to try to get across the blood-brain barrier. And perhaps there will be some AAVs that are better at doing that than others. And there are obviously, at least I hear rumors that there are things other than AAV in the world, go figure. But perhaps other methods would work. But we've also been collaborating and trying to help our colleagues along with using AAV safely in direct injections, either into the spinal fluid or into the brain parenchyma itself. And I'm going to show an example where we did that. We actually did a combination of intrathecal cisterna magna and biothalamic injection. But this is the concept, right? So that the more invasive you get inside the brain parenchyma, the lower the dose is. ICV is a bit bigger, cisterna magna, intrathecal, and then you get to really high doses with IV. Now, one strategy some people are using is to try to make a better mousetrap, better AAVs that are developed either empirically or to target certain pathways that have been evolved for transcytosis of the endothelium in the brain. So there are receptors for things like transferrin and insulin, and for glucose and amino acids. And one example of this that's been used for other kinds of drug delivery is targeting the transferrin receptor. This is another strategy. It was actually the pathway was defined in 1987, which is a long time ago, even for an old guy like me. And this is actually first used in 91 to transfer antibody drug conjugates. So this is not a new idea. Applying it to AAV is new. And that's what Ben Deverman did, and many have reproduced this. What he did was he made a transgenic mouse that had a knock-in for the human transferrin receptor. And what he was essentially able to show is that he was able to achieve similar levels of transgene expression with a much lower dose. You see, the low dose here, he got similar proportions of neurons transduced with a dose somewhere between 10 and 100-fold lower. Now, that seemed like it might be the right answer. Um, but we're not quite sure in the field right now because there was one trial done by a company called Capsida with an AAV capsid that is not what they did not publish the identity of, and maybe somebody on the call knows what it is, but I don't believe it is known. We do not think it was transferrin receptor targeted, but we don't know. And unfortunately, tragically, really, the first patient on that in that trial developed cerebral edema and died. And this has really, as the highlight from stats says, unnerved people about jumping right in with higher blood-brain barrier penetration. A lot, as I said, each one of these things, there's a lot more we have to dissect about these and try to figure out why these toxicities come up in humans that we haven't seen in the preclinical models. Brings us back though to this direct injection idea. So I'm gonna take this forward now and talk about and this actual trial that I was actually recruited to run by colleagues who are neuroscientists, which I am not. And this was using an AV RH8. This is not AV8. It's different. It's more related to AV9. It's clade F neurotropic virus. And to be honest, it's probably fairly equivalent to AV9. And it's an AAV. Of course, you guys know what those are, so I won't go over that again. And these are the scientists whose work this really was, and they needed a clinical trial person, and it turned out I was the one who had experience with younger patients, and so been I was very fortunate to get involved in this collaboration and for the last 7 or 8 years. Miguel Estevez devised this approach where it's actually treating a condition called Tay-Sachs disease and another condition called Sandhoff disease. These are two genes that encode two subunits of a heterodimeric enzyme, hexosaminidase A, which degrades GM2 gangliosides. Now, the nomenclature is weird because hex A is the gene for the alpha subunit, hex B is the gene for the beta subunit, but the enzyme naming convention is the hex A heterodimer, the active enzyme is the heterodimer, and a homodimer of the gene product of hex A, the alpha subunit, is called hex S. Don't blame me that I didn't invent that. But anyhow, in order for this enzyme to work well in a gene transfer context, the cells that are expressing the hex A have to also be expressing the hex B. Single gene defects in hex A lead to Tay-Sachs disease and hex B lead to Sandhoff disease, but the combined hex A, hex B gene combination is a treatment for either disease. And in this case, this was done with two separate vectors mixed together in equal molar portions. You see both are chicken beta actin driven. This was actually a bit of a tuned down promoter. It was not the most active version of the CB promoter because there was some concern about overexpression toxicity. So what did they do? Well, to take 10 years of their work and put it on a third of a slide, they devised this, they call this monocystronic combination, and they were able to demonstrate correction of a Sandhoff disease mouse model, a Sandhoff disease cat model, and a naturally occurring Tay-Sachs sheep model. Heather Gray Edwards, shown here, has partnered all the way along with Miguel. She is a DVM PhD who first developed this phenotyping and gene therapy in the Tay-Sachs sheep model, along with her colleagues when she was at Auburn. She's now at UMass Chan along with Miguel and myself. Now, what they devised to do, which I thought was really ingenious, is they found that in these larger animal models, they were able, if they injected vector into the thalamus, to get axonal transport of the enzyme over the entire hemisphere of that side of the brain that they had injected, taking advantage of the anterior grade transport of enzyme. And because this is a lysosomal enzyme, many of you recognize that those have the capability, when they're overexpressed in a cell, not only to repopulate their own lysosomes with the missing enzyme, but to secrete a portion of it and have it taken up by adjacent cells through cross correction through the mannose-6-phosphate receptor pathway. Okay, all of a sudden I'm having trouble advancing. Okay. Now, the clinical trial, we actually did a small N of 2, was started as an N of 1 trial just to look at feasibility of delivery, but then did this clinical trial trying to bend the curve, if you will, of uh, the degeneration that is observed in infants with the most severe form of GM2 deficiency, generally Tay-Sachs or Sandhoff. So the way this works is that the most severe disease is the early onset disease. These patients are often begin to have symptoms noticed by family at between 5 and 10 months. You see there, this is the age in months and the different characteristics where they begin to experience these symptoms. They're often not diagnosed till somewhere around here, around age 12 months, to get the actual definitive diagnosis, unless they happen to have had a sibling or some other family history, and then they have a very rapid downhill decline. If the disease is less severe, if there's more residual enzyme activity, the onset can be later or even into adulthood. But the trial that was done was to try to interrupt this terrible progression of the disease. This was a trial that was done where we at UMass Chan managed, the treatment of the patients and the immune suppression, and Florian Eichler, our colleague, neuromuscular neurologist at Mass General, independently measured all the outcomes. And so this was a great team. Heather was our main interface with the preclinical modeling. And Özcal Tepe here was the brilliant pediatric neurosurgeon who figured out how to do this safely in these very young infants. And many other people participated in this in important ways. This was a 4-dose level trial. And in infantile Tay-Sachs and Sandhoff, patients were immune suppressed with 3 drugs, as I mentioned, anti-B cell antibody, sirolimus, which is an mTOR inhibitor, and steroids. The patients got this bithalamic injection. It was actually an MRI from right after injection. You see this wider area here is the thalamus where the injection went. But also they got injected into the spinal fluid in the cisterna magna at the base of the brain, and in the conventional thoracolumbar intrathecal space. The doses, you can see, we're doubling doses, limited really by the volume to be infused into the thalamus. And they went from roughly 10 to the 14 total, counting between the CSF and the parenchymal injection, up to 4 times 10 to the 14, with doubling doses of the vector based on the infusion volume. And these 180 microliters, 360, that was the amount infused into the thalamus, with the remainder of the vector given by the CSF routes. Oh, I should say that initially the FDA wanted us to treat juvenile patients at each dose level just to get the techniques worked out. It turned out they were more prone to an unusual dystonic movement disorder that we'll be describing in greater detail in a subsequent paper. But in the infants, this really worked really well. Here's Dr. Chadaltepa using this robotic arm. These babies' skulls were too pliable to go into a stereotactic frame, so what he did, and we didn't do it, he did it. He used MRI guidance to use this robotic arm to advance the catheter directly into the center of the thalamus for infusion. And you can see here the volumes of infusion overlaid over the images of the thalamus. And as predicted, the more we put in, the higher coverage we got up to, close to, well over 50%. And you can just see some of the other images here. Now, I've run through a lot of data, but just to say what we were able to demonstrate here were a couple of things. One was that the enzyme activity could be restored in the CSF in a dose-related fashion. These were the low dose, the mid dose, the high dose. This assay only worked on the Tay-Sachs, not on the Sandoff patients, so we didn't have all the patients plotted here. Also, you see the vector, the expression actually peaked at 12 weeks and then came down, which was not necessarily expected. We also saw the same thing by DNA tractigraphy, which is showing the growth of new neuronal tracts. Don't ask me the details of this because I don't really know them, but I will say that the net fiber tract number again, it peaked at what was the biggest growth was up at the 12-week time frame, and then they all seem to go down. It's consistent with the enzymatic activity. What we observed is that these patients actually did not get better across the board, but they definitely had a prolonged ability to feed orally. So I ended up plotting this as a like a Kaplan-Meier curve and looked at the loss of oral feeding, or the percent that's maintained oral feeding. And when we used the criteria of just did they have aspiration, pneumonia or not, we had a really longer duration of oral feeding shown here on the top. This was with all the infantile patients. It turned out that our contemporary control group had the same timing of loss of swallowing, marked here as dysphagia, around 15 months. At the 50% loss point for swallowing in our controls was right at the same. We had patients, if we just wanted to look at any need for a G-tube, that was plotted in blue here. That was certainly delayed by quite a lot, although these patients got gastrostomy tubes for nutrition and hydration. They were not having aspiration pneumonias. So many, if you just looked at the absence of aspiration, we had quite an important effect. And interestingly, while this was far from a full cure, this turns out to be an ability that is important in the quality of life as parents describe it. Florian also described, he did many standardized neuro scores when he looked at the seizure severity and the swallowing dysfunction. He showed that the highest doses had the lowest levels of severity on this assay, on this scale, I should say, the lower numbers are better. So he did confirm this. Now, I'm going to stop there and just say I could talk a lot about the conclusions from this or why it peaked and came down, but I'm going to shift gears again in this ambitious talk and talk about something that happened in the middle of this trial that led us to a whole different discussion. So here's the timing of what went on in this trial. In January 2021, the first patient was dosed on an industry-sponsored IND. In mid-April of 2022, the company that was the sponsor of the trial announced on Twitter that they were discontinuing the program. They did not call us or the patients. We were not very happy about that. And in fact, we were able to take over the trial and to finish it with funds from the foundation and the university. And I have to say, I thought that we were uniquely experiencing this at the time, but it turns out that was not the case. This is just to show you, yes, that these there are faces and names of the kids who would not have had the opportunity to get whatever benefit was present there. And also, of course, any of the subsequent trials we're going to do were slowed down by this. But what happened is, at our group, one of our aspiring students actually did did a literature review, kind of all particularly the trade literature in biotech, and actually found 50 different programs that were at or near clinical stage, and in some cases even where products had already been approved or were in preparation in the midst of a BLA application where they were discontinued. This was very disturbing. This was published in 2024. And this is what we took back to the society. Now, mostly in our society in ASGCT, we talk about science. We run an annual meeting, which is a hotbed of science. But our mission, we feel, in addition to facilitating the innovations and communicating our science and training, what we really think what pulls it together is that we want to see patients have access to cell and gene therapy. Whatever the current technology is, and it's not perfect, certainly not with AAV, we believe it's our obligation to have it accessible to patients. And so I'm not going to go into any details on this, but we assembled. Matt was a very big part of this, and we pulled all this together to assemble a working group for commercially pre-viable, is what we called it. We don't want to call them non-viable because we think they will come back. And we came up with a variety of ideas of how to try to keep those therapies there and available. And the first one that took form was actually developing a clearinghouse and a marketplace. So that, let's go back on our trial as the program was stopped, we were able to extract the IT, claw it back, sorry, the IP, claw it back to the university. But in many cases, the IP then just sits and is unused. And we've created an entity to try to find new homes for these abandoned programs. In a parallel effort that is just getting underway, that Stephen Gray from UT Southwest is leading, we're trying to develop also a consortium of lower cost manufacturers, which could also help make the technology more available. So you're going to have to come to the meeting to find out a little more about this, but this exchange we created for shelved therapies got a good bit of coverage. It was the first that we know of having been created for this purpose. And it is now active. It's called the CGT Exchange. And what it does is it is an AI-enabled digital platform that is creating this listing for therapies that might be products that might be available and programs that might be available to be relicensed or rehomed, if you will, to move them forward, whether they have been dropped by a prior commercial sponsor or whether they're just being brought forward by an academic institution or a patient advocacy organization. And I had other slides on that, but I decided to leave them out. So I'll just end by thanking some of the people who were involved in all of these studies. I can't name them all. I do want to acknowledge very much our friends at University of Missouri, the Dewan Lab and Matt Burke for all the work with the dogs. And Juliet and Jim and Peter become very good collaborators for us in this whole endothelial cell project. So I think that's more than enough to talk about one afternoon. So I'm going to end my talk, stop my share so I can see people. There we go. And happy to take questions.
Thank you, Terry, for that tour of the AAV field and some of the successes and challenges and how it's even uh, informed how we're going to think about developing these cell and gene therapies for rare diseases or shelf gene therapies. Really appreciate it. Um, does anybody have any questions or comments? You can either unmute yourself or post it in the chat, and I can help moderate. Um, as I give people time to think through their questions, one thing I have um, is going back to your roots in cystic fibrosis, AAV gene therapy. Do you think the aerosolized route then becomes how do you, maybe I'll phrase it more broadly, aerosolized AAV as a way to treat CF and as a potential solution to this lung endothelial damage?
Yeah, well, I think certainly in the target of the epithelial surface, then that that mode of delivery is has the potential to, as again, get more to the target cells. One of the problems with the initial trials is the episomal nature of most of the AAV. It's not all episomal, but the episomal nature of most of it, which I know
Yep.
Mark characterized very well early on in the field. The that means as these cells turn over, we lose vector genomes. So what we're working on right now actually is we're actually working on delivery of gene editors, gene editing technology, Cas9s. The ones it's interesting. We're trying to develop because they're great drugs now for small molecules for CF. We're trying to develop a an approach um, that essentially harnesses the CFTR promoter and inserts the coding sequence or what we call super exons. So it's the CD, it's not exactly the cDNA. It has one intron in it. But we're working on this with some funding from the CF Foundation and some novel ways to try to get to the basal cells in the endothelium. I'm sorry, in the epithelium, which are the repopulating cells. But it's a great question. I think, it's not coincidental that the first approved AAV product in the US anyway, Luxturna, involves a local injection in a very small space in the subretina in the eye. And that seems, obviously where localized injections can work, that obviously avoids a lot of the problems. Muscular dystrophies, are real tough nut to crack. And so that's why a lot of these technologies are being challenged in that area. And then, of course, in the area of the CNS, I mean, I presented the feasibility of doing things like intrathalamic injection and into the spinal fluid, but the distribution is really not sufficient to really get the proportion of neurons treated that you need for many of these diseases. So there's some big gaps in delivery still.
So Terry, can I ask you to follow up on the CF issue? If you
Yeah.
were targeting non-basal cells and you're using an editor and it was something you could re-administer, how often would you have to re-administer? Because there is some, turnover. And secondly, what proportion of the cells do you think you would need to hit and the distribution of those cells throughout the lung to really make a difference in CF?
Yeah, I mean, all great questions. I think there's some data on some to answer some of those. The uh, uninjured lung, the turnovers every 3 to 4 months. The inflamed lung, which it may be, and many patients with CF, it can be as quick as 3 to 4 weeks. So that's a serious issue if you can't get to the progenitor cells. So we really the strategy we're doing, and it's really tightly linked with Guangping and several others here, is to develop a novel strategy where we're actually targeting basal cells with ligands inserted. And I didn't want to scare anybody about this, but we're actually doing this with modified recombinant adenoviruses that rather than AAV, so a bigger payload. And but these have 5 mutations in the capsid, as well as several deletions in the antiviral genome, and ultimately we'll have the insertion of some of these targeting ligands for basal cells and for the we used to call Clara cells or club cells in the more distal airways. CF is a disease of both small airways and large airways, mostly the conducting airways, not the air spaces or the alveoli. And but it is both, and so it needs a really broad distribution. So these are tough technical questions, and you can see why it's been so important that other strategies have developed. Um, but yeah, so I think to get that broad distribution, we may end up back with an IV approach. And we're certainly studying both.
Okay, thanks. Great talk.
Yeah,
Thanks.
and don't see another question, so I'll take the opportunity. I think the one of the throughput themes of your talk is um, the challenges of predicting human toxicity, uh, with particularly with novel serotypes of AAV. Um, and then, I think going back to the dogs and looking for what we already found in humans is nice, but of course, we'd rather have found it in dogs and said, you know what, probably we shouldn't do this in humans. So, how should we be thinking about evaluating these non-nature derived serotypes for their potential toxicity in humans when we haven't seen those toxicities in dogs, non-human primates, or other models? Nice
It's
small question for you.
Yeah, no, it's a great question, and it's one of the reasons actually, paradoxically, people are saying, well, why are we spending so much time doing all of these preclinical studies when they're not really very predictive? And of course, you can always, when you're in a hurry to get to the clinic, you can always come up with that idea. And you know, I I don't. All I can tell you is that I have found that for many situations, whether it's a toxicity or a primary pathology of the disease, you really have to manipulate a genetic model. I mean, a genetic model is great because then you can determine, is this a genotype specific phenomenon, and does correcting the gene treated. But I think animal models as they currently exist are very, very imperfect. Uh, that's part of the push for this, what the FDA calls this a new approach methodologies, which, I think the plus side is, you can look at mutation-specific changes, right? Now you do iPS cells, iPS-derived organoids. You can find out a lot from that about efficacy, but much of this safety involves an immune system, and it's we've got to
So
keep trying.
So, yeah, so Terry, remember in the hemophilia trial that we did, the dog model, the genetic dog model really replicates the human disease, but that whole T cell issue came up, even though we never saw this in dogs or even other animal models until you tried it in humans. And that's a big surprise. I mean, was a big surprise back then. And I guess, in terms of this endothelial toxicity that you saw with the Duchenne's, if you had a bet, do you think it's leaky transgene expression or the capsids getting into the endothelial cells? If you were going to bet right now.
I'm going to bet that the decreasing the transgene overexpression is going to help. I don't think, I've just been reviewing a paper about this where they try to do this more generically with looking at gene expression changes at high doses in a couple of species. And it's pretty clear that when you get to high doses, you have several acute effects. One is from putting all these AAV genomes, which essentially are DNA fragments, into the nucleus. So you get all of this DNA repair, P53 pathway activation. And then, another one is innate immunity, of course. And then you also have the effects of the transgene overexpression. And it seems like all of those are detrimental and that they may be additive or synergistic. So I don't believe that one thing is gonna work. You know, I tell you, I'm interested in what you guys think, particularly you, Mark, about this cerebral edema in the capsida trial. I mean, it would help to know what the capsid was, but what do you think about that?
So one thing I heard as an idea was that whatever the receptor was that was being used to transient through the BBB was actually being blocked, and then it was allowing for dysfunction of the BBB. So it was a secondary effect due to that. I mean, I think it's an interesting idea, but again, who knows? Yeah.
Yeah.
Another failure of the preclinical models.
Yeah.
And
Yeah.
and the
One,
question is, it's unfortunate it was the first patient because could this be something really bizarre with one patient, right? Versus something that would happen a lot. It's going to be hard to decide that based on the fact that the ethics of starting the trial again, or maybe starting again at lower dosing, things like that.
I know we're over time, but we had one more question in the chat, and I'll paraphrase it is AAV, we have a, well, 30-year clinical history since 1995, and we're in 2026. Is it still the gold standard vector for in vivo gene therapy? Or is there something that's going to replace it that you see in the near-term horizon? I think I paraphrased Deanna's question.
Uh, it pains me to say this, but I think for some target sites that LNPs are going to get there.
Yeah.
We're really getting there with those, and I think that purely, truly synthetic molecules that like LNP components that you can characterize more precisely are going to have some inherent advantages.
Yeah.
So I don't think AV is going to be totally displaced from the field during my career
Yeah.
time, but
Yeah.
we may see the day when there's a lot of displacement.
I think AAV will always be part of our toolbox. So I'll be uh, and I have less skin in the game than Terry or Mark. So let's all join in a round of applause for Terry taking time out of his busy day to educate us all to this field. So thank you very much, Terry.
Well, thank you guys. Thanks, Matt. Thanks, everyone. I just a lot of fun. A lot
Great.
better than my day job as say that.
Well, see you in Boston.
See you there.
Aye.
Bye bye.